morning. My name is Shanika Jerger Butts, and I am a first-year public health sciences doctoral student at the University of North Carolina at Charlotte. Today, I have the distinct pleasure of presenting my research to you in the form of a poster presentation entitled Pre-Pregnancy Hypertension, Pre-Pregnancy Diabetes, and Prenatal Care Timing. The aim of the study was to evaluate the association between pre-pregnancy hypertension and pre-pregnancy diabetes and when prenatal care was received among U.S. women who had recently had a live birth. In 2019, the prevalence of hypertension in U.S. women of reproductive age was 9.3%, and the prevalence of diabetes in U.S. women of reproductive age was 4.5%. Women who begin pregnancy with hypertensive or diabetic diagnosis have an increased risk of pregnancy complications and adverse birth outcomes such as preeclampsia, placental abruption, stillbirth, infants born for gestational age, congenital disorders, and also fetal and maternal death. Prenatal care received in the first trimester of pregnancy allows for necessary routine testing, treatments, and interventions that aid in controlling these pre-existing conditions such as hypertension and diabetes. For the analysis, the data analysis used in this study, we use SAS to conduct a multivariate regression analysis using 2018 US birth certificate data, which included over 3.5 million women. The exposure variable using the analysis were pre-pregnancy hypertension and pre-pregnancy diabetes. And the outcome variable was when the timing of when prenatal care visits began for the women. Moving to the results of the study, most of the women in the study were 25 to 34 years old and non-Hispanic white. Nearly 1% of the women were diagnosed with diabetes prior to the onset of pregnancy, and 2% of women had hypertension prior to pregnancy. Over 2/3 of the women in the study had received early prenatal care, which is wonderful news. In contrast, nearly 780,000 women did not receive prenatal care in the first trimester of pregnancy. Now, before adjustments were made in the analysis, women who had pre-pregnancy hypertension and pre-pregnancy diabetes had increased odds of receiving prenatal care compared to women without these pre-existing conditions. Women 30 to 44 years old had increased odds of obtaining prenatal care. However, there was not a strong association for women in the older category of 40 to 44 years old. Also, there were decreased odds of receiving early prenatal care for women aged 18 to 24 years old. Interestingly, before adjustments, all minority race ethnic groups showed decreased odds of receiving early prenatal care. And these findings were statistically significant. Now, after controlling for age, race, ethnicity, marital status, educational level, insurance status, WIC coverage, and the attendant at birth, the association between exposures and early prenatal care reception increased in magnitude. In fact, with 24% increased odds for women with pre-existing hypertension and 29% increased odds for women with pre-pregnancy diabetes, compared to those women without these conditions prior to pregnancy. Finally, we wanted to determine if race ethnicity affected these associations in any way. Race ethnicity proved to be an effect modifier to women with pre-existing hypertension and diabetes, and if they received prenatal care in the first trimester. This study confirmed that among women of color, those diagnosed with pre-existing hypertension and pre-existing diabetes have statistically significant increased odds of receiving early prenatal care, which was wonderful news. Therefore, women who are at a high risk for complications are in fact being seen at the earliest opportunity in their pregnancies. Given that women of color experience disparities of receiving prenatal care, we hypothesized that our stratified analysis would expose those disparities. However, these disparities were not indicated in our findings, as I mentioned earlier. Our findings confirm, based on research, that outreach activities addressing the barriers to care have been successful in increasing the reception of prenatal care in women of color. As these organizations continue to persist in creating ways of reducing the disparities that plague communities of color, prenatal care visits in the first trimester will continue to increase. Early prenatal care is on a continuum with preconception care. Patient education regarding disease management, such as continuing encouragement to continue to continue their current treatment plans, medication adherence, and maintaining healthy lifestyle behaviors is received during preconception care visits. The level of preconception care received by women with these pre-existing conditions like hypertension and diabetes may be a good indicator to tell us when the transition into prenatal care will occur, or if it will occur once pregnancy happens. In conclusion, although these findings are encouraging, there is still work to be done to increase access to early prenatal care and prenatal care in general. Also, there's room for improvement in maternal health inequities, and also the gap still needs to be narrowed in maternal mortality in the United States. I thank you so much for your attentiveness as I presented my findings to you. If you have any questions regarding what I presented, please feel free to reach out to me. My email is listed on the poster. I thank you so much, and I hope you have a wonderful conference, and I hope you have a wonderful rest of your day. Thank you. Bye-bye.